I'm Sonya. I'm a health economist, but my professional practice is an evaluation lead at UBC Digital Emergency Medicine, and I have a faculty appointment at Simon Fraser University in the Faculty of Health Sciences. I think the biggest challenge is that we don't have enough researchers from the communities as part of the team informing some of the metrics that we use to measure progress on our equity objectives, on our economic objectives, and having that rural context and that understanding of what it's like to live in a rural community. I think that's one of the biggest challenges. I absolutely love metrics because you can't change what you can't see, right? And it gives you like a dial to sort of know when you're pushing the needle on being able to reach rural populations or improve their access. So that'd be the first one, I think, is improving the distribution of access of health services to rural communities. Anything related to the slope of index of inequality, that's one of my favorite ones, where you can look at how different the distribution is between rural and urban comparisons, or you can use different indices to measure the distribution of access. A really important one, I think, is financial hardship. When patients don't have enough money to travel to a medical appointment, and they need to in order to get the care. That's a really important one for us to keep an eye on, is how is the impact on patients' and families and their income and what they have available to do the medical travel in rural areas. That is the question. Like, we need these definitions. Rural, it isn't very well defined. There can be rural where you're geographically, topographically, or environmentally isolated. Or there can be rural that's just far enough outside of an urban center to call it rural. So you get the washing out of what the health service delivery objectives are. And so I think what we need to do is to do better at defining rural. There isn't a good answer. We need a better way to look at inequities that are specific for rural, remote, and Indigenous communities and get at a combined number of factors that lead to these inequities in health that we see. We can use access just looking at administrative records, and we can say, yes, they did have access to the service, sort of looking back retrospectively, and we've got some starting points to be able to measure differences in access compared to the general population and urban counterparts. So there's that, but I think your question's really good because there's access, different levels of access, like if they don't have the finances, that includes, it changes their ability to access healthcare, as well as if they feel safe. Like if they've been discriminated against in the past, patients might not feel that they can truly access healthcare. This one, it strikes home personally very close to my heart. I have been working with an Indigenous community with Wet'suwet'en knowledge in Pacific Northwest of BC. And this work has taken years of relational investment. It's taken years of me going in and letting go of everything I know and being able to learn with a community in a really, truly, mutually respectful co-learning experience where we start to understand what are the differences in these communities and the contexts that are not considered in urban settings where I'm from. Yeah, so it takes a long time, and it takes trust and relationship building, and that's not easy to do. There's so much to be hopeful for. I work in digital health, so there's all these new innovative solutions with people who share the same interest in reducing inequities. And for example, the Real-Time Virtual Support Network, it's a group of physician services and peer-to-peer support pathways to reach patients virtually with relationship-centered care at its heart, so that they're leading with their hearts to reach people, which I thought was quite innovative and creative. The drone transport delivery for medications to people that can save them thousands of dollars every year for travel to pharmacies where they don't necessarily need to. They could have and some people have a really difficult time making those regular trips into town. So I think the technology has a lot of potential also to learn with AI and machine learning. You can look at patterns and say something's wrong and act on it now with things that we couldn't see in the past. So I have a lot of hope in the area of digital health and the data that's available to us now.